right, so welcome back to the end of the 2020 Gilder Fellows. So we've heard a lot of, I hope, sort of happy topics, and so we decided to end with something maybe less happy, but I hope to give you some hopeful signs. As I mentioned earlier, I used the quarantine time, so all the time that I would have spent commuting to class and traveling to speak, to work on a book actually on the COVID-19 coronavirus panic. And my co-authors are Doug Axe, who's a longtime friend, now a professor of biology at Biola University, and a statistician named William Briggs. And my interest in the coronavirus event, not the virus itself, actually started in early March. And it was the worry of the way in which a particular group of experts and particular officials who had direct access to the levers of power, that is to influential politicians, were giving advice based not upon solid scientific data and information, but based on a couple of very speculative computer models. And so I had for years been sort of worried about the role of computer models, especially the speculative statistical models, in the role of public policy, because they are essentially complex arguments. And so unfortunately, if you were to sort of follow the media line on models, they will be presented as studies, as if they're actual data, actual information, as if you've done some kind of field study. When in fact, what a computer model is, these speculative models, unless you're able to test them against the evidence, are essentially really complicated statistical arguments. But that doesn't have the kind of political power, certainly not the kind of staying power, persuasive power that a model that you imagine to be a study would, right? So if somebody said, well, a couple of guys had made a really complicated and opaque argument on a computer, and the conclusion of their argument is that millions of people are going to die if we don't do this, that's not all that persuasive. But if you say the model is a study and that it's somehow just essentially an analysis of real facts out there in the world, then that has the ability, as we've discovered, to completely reorient the global economy. So it's not like I was a skeptic about viral infections or something like that. Of course, neither are my co-authors, but the three of us independently were actually very, very worried early on in March about what was happening. We didn't initially know anything about this particular coronavirus except what we were being told by the media. But we realized very early on that a single computer model by Imperial College London was playing far too much of a role in influencing public policy, both at the global level and in the United States at the national level. So the book comes out in October. In fact, I've never even talked about it until just now. So this has been essentially us hunkered down to get the book out. And honestly, the reason we decided to write the book, even though we didn't really have it in our schedule, is that we were worried about the same rhetorical tricks, frankly, that were used the initial time around being used again in the fall. Because if this coronavirus that's associated with the illness COVID-19, right, if it's what in all appearances is, it's going to be a seasonal respiratory virus. We may all develop an immunity and not have to deal with it long term. But if it's anything like the flu or the cold, it's going to have a sort of seasonal trajectory. And if the lockdowns were a terrible idea the first time, we wanted to be able to make that case. We wanted to be able to say, look, before we go through this exercise again, we need to make the case that this didn't make any sense. So let me just sort of lay out what I think happened, how it happened, and why I think is actually a mistake. At least the draconian government lockdowns that we saw in many states in the United States, the kind of lockdowns that ended up being encouraged by the World Health Organization, are almost certainly not only a mistake, but the costs have greatly exceeded the benefits. So that's what we wanted to be able to do, is to be able to, insofar as we could look at the data that was actually available and reported, could we see if these draconian responses actually had an effect or not? And I was pleased that it looks like the evidence is robust enough that we were able to show that no, in fact, they weren't. It doesn't mean that nothing makes any difference, but it means that probably these draconian lockdowns in which you force people to shelter in place, healthy and unhealthy alike, have far more costs and benefits. In fact, they may have almost no benefits. So what happened? Let's kind of start at the beginning. I don't know, most of you have sort of been living through this, and so you're going to have a general memory of this, but sometime in January in the United States, we heard about this mysterious virus that was initially at the time supposedly from a wet market in China, probably initially transmitted by a bat, because it's very similar to certain types of bats. Bats in particular places in China are known to carry this virus, and we heard about it breaking out in Wuhan in central China. That's sort of all we know and all we knew at the time, right? And there was a worry about this. What's funny is that a lot of people don't remember, but very early on in January, President Trump, the president of the United States, ordered restrictions in travel to and from China in response to this coronavirus. And if those of you that aren't Americans that are on these seminars may not know, but he was attacked for this in late January by his political opponents, who actually called him xenophobic. So, you know, it was sort of anti-foreigner to do this. And in fact, Nancy Pelosi, at the very time the outbreaks were happening in China and President Trump was restricting travel from China, was actually encouraging San Franciscans to visit Chinatown. What connection this had to anything, we don't know. Well, by March, the story had completely changed. And in fact, he was being attacked for not being aggressive enough in his response to the coronavirus. And so I guess the presumption was that we were all going to forget what had just happened 2 months before. Now, in fact, I think the president had fairly good instincts. He knew, okay, this could be a serious problem, but we don't want, he said at the time, we don't want the cure to be worse than the disease. That was the worry, is that our response would end up incurring greater costs than the actual benefit. The problem is we didn't have a lot of data, except that we knew that this was contagious and that it could kill some people and it could create really negative sort of respiratory symptoms in other people. We just simply didn't have a lot of information at the time to figure out, okay, how dangerous was this thing? And that's really, really crucial. You want your response to a risk to be calibrated to the real risk, right? If you overreact to something, overreaction by definition means that you overestimated the risk to the thing. And so your response can end up having a greater cost than the thing you were trying to avoid. So what did we do? We relied on a single predictive model by a team of 30 from the Imperial College London, led by a guy named Neil Ferguson. So not the Neil Ferguson who writes on finance and history. This is a different guy. And what did the speculative model say? Well, I don't want to get into the details. We've got an entire chapter on modeling in the book, but the prediction of this model, for those of you that don't remember, was that without very draconian mitigation, the coronavirus was likely to cause in the next year 40 million or so deaths globally and about 2.2 million deaths in the United States. So what that meant is that's the magnitude of the 1918 Spanish flu. So this was the worst outbreak of this sort in terms of deaths in the 20th century. In fact, the World Health Organization counts the Spanish flu as the only really, really severe pandemic of the 20th century. And so they were saying that if we did not respond sort of in the way that we responded in the United States, 40 million deaths globally, 2.2 million deaths in the United States. Now, what was the basis for this? Well, it turns out there was no basis for this at the time. This was based entirely on speculative inputs about how contagious the coronavirus was and how deadly the coronavirus was. But we did not have that information at the time. And so you would think that something like this would have been treated as a sort of academic exercise. Well, that's interesting. Okay, if that's what would happen if we sort of assumed the truth of the model. And in a normal world, you'd have academics doing this, but they would not have direct influence on politicians. Politicians in democratically elected polities are supposed to exercise prudence. So they have advisors that have academic specialties, but prudence requires that you say, okay, my epidemiologist is always terrified about a pandemic that's going to kill everyone, because that's the only thing he focuses on. And so the last thing you want is for that guy his advice alone, right, to be able to dictate policy. What you do as a politician is you take into account his particular specialty and his bias, and then you weigh the advice of different specialists, all of whom have their biases, in a way that hopefully serves the common good in some ways. That was essentially short-circuited. And the way it was short-circuited is the World Health Organization, so the Secretary General, who is an Ethiopian biologist who was a politician in an ethno-communist party in Ethiopia for many years, right? It's still, so far as we can tell, a dedicated communist. Now the Secretary General of the United Nations glommed on to this one Imperial College London study. And that essentially spread virally, those numbers. So those are the numbers people still remember. It's the number that stuck in the head of the President of the United States, Donald Trump, is 2.2 million people, right? Now remember, this is the speculative computer model, so it goes from there, and then the viral infection, the mental meme, right, goes from there to the Secretary General of the World Health Organization, to particular public health entities in the United States government. And so what happened? Well, in the United States in particular, President Trump was ultimately persuaded that if he didn't do anything, millions of Americans were going to die. Here's what he said in April 8th. He's referring back to what he had advised at the federal level and advised the American states to do back in March. Here's what he said. He said, the big projection being that 2.2 million people would die if we did nothing. So that was another decision we made. Close it up. That was a big decision that we made. Two very smart people walked into my office and said, listen, these are your alternatives. And that was a projection of 1.5 to 2.2 million people would die if we didn't close it up. Two very smart people. So let that just kind of hang in the air for a minute. Two very smart people. One was almost certainly Dr. Anthony Fauci, who has become a kind of media figure. He threw out a pitch at a baseball game actually just this week. The celebrated figure, and we don't know for sure who the other person was, but two public health officials, all right, could speak to the President of the United States, the most powerful person on the planet, and give them a number of 2.2 million deaths. Now, if you're the president, right, essentially in an election year, and you're told if you don't do this thing, over 2 million people are going to die of this disease on your watch, what are you going to do? I mean, all things being equal, what are you going to do? Now, if this is a private meeting, right, and the president actually understood the kind of advice he was being given, and the basis on which that advice is being given, he would discount it properly. Unfortunately, that's not only did that not happen, but instead of this being a private advisor in the sort of bowels of the administrative state, that advice and that information was amplified by both the regular media, the print, right, and broadcast media, and by social media. So that what would have otherwise been this kind of highly eccentric advice that might have been sort of thought about ended up becoming national and in many cases international policy. Now we knew within 2 weeks that the model was complete junk. In fact, it generated different things every time it was run. When they finally released the details of the model, they actually edited it before they released it. So it was just an absolute complete disaster. If you're wondering, well, maybe Neil Ferguson was a very trusted scientist. In fact, he has an almost perfect record of absurd predictions that have been proved wrong in his 20 or so years in service, and he's never suffered for that. So let me give you just one example. It's so crazy, it sounds like we're making this stuff up. So one piece of advice from Neil Ferguson in 2005, he suggested that perhaps 200 million people could die of the bird flu at the time. Well, so what were the numbers according to the World Health Organization between 2003 and 2015? 440 people died. All right, 200 million. So the way you respond to something that could kill 200 million people is going to be a little different than the way you'd respond if it's 400. But notice now, why would he do this, and why wouldn't he suffer for it? Why, you know, and that's just one example of disastrous predictions like this that he's made. Well, the reason is because of the incentives that it works in public health. So imagine you're the guy that has to tell the president, you tell him that 1 million people are going to die unless we do this thing, and then they do this thing, and then only 1,000 die, right? You get two ways out. Either look, it's a good thing we responded, right? Because 1 million people didn't die. It's because we responded. Or at the very least, you could say, well, it's a good thing that we responded, and better safe than sorry, right? That's essentially the thing. Now imagine you're the guy that says, well, probably only 100 people will die, and then 10,000 die, right? The punishment is all in one direction. So in one direction, you're forgiven, and we quickly forget the advice because you overshot. If you undershoot, well, you're looking for another job and probably trying to hide your address, right? So you don't get doxxed. So all the incentives are in the direction for public health officials of exaggerating threats rather than calibrating and looking for the precise level of risk and then adjusting response to that. And so in a normal situation, public health officials, their advice is going to be discounted by this kind of intrinsic incentive. So that's what happened. So we responded in a way that might have been appropriate if it had been truly as pathogenic and as deadly as we believe. The problem is that the response vastly, unfortunately, overshot. So that was the first thing, is this weird kind of scenario in which you had public health officials that would otherwise be obscure, whose advice is then amplified by media and social media and lionized, which in some ways, I'm focusing on the United States. This happened in many countries around the world in which democratically elected politicians actually forced into doing something. Because the reality is, if you're a public official, it's more important for your political success that you be seen doing something than that you actually do something that helps people. I mean, this is half of economic policy. You have a recession or you have a financial crisis. It might be that the very best thing you could do is let the market correct and adjust, but you can't be seen doing that. You have to be seen doing something, even if it doesn't help. It's the same thing, unfortunately, with public health. And so politicians in democratically elected countries generally had to be seen as responding in some way. So how did we respond? Well, some of the things that we did, strangely enough, so closing public schools, forcibly closing large numbers of businesses, and forcing people to shelter in place, right? Now, this sounds commonsensical to us. It sounds like, okay, well, if a virus is transmitted from person to person, either because we sneeze or we cough or we spit, right, or we touch surfaces and we move these virus particles around to each other, so that if we spread each other out and sort of lock ourselves down in our houses, and so we don't go to work and we don't go to Whole Foods, right, and we can't go to the beach, then we're gonna reduce the transmission. That's the sort of common sense. It's not true, though. In fact, there's absolutely no data that this type of sheltering in place, we have no data that this is the way you stop a respiratory virus. Weirdly enough, the witness for the prosecution is the World Health Organization itself. In October of 2019, so last October, they issued a report in which it was essentially a meta study of other studies of different ways of responding to contagious viruses like this. It wasn't focused on the coronavirus because we didn't know about it at the time. And so essentially what they said is, okay, what about closing schools, closing businesses, drastically restricting travel? What about masks? What about washing our hands? Okay, this is depressing. But in every one of these cases, they said the data is quite thin, that these will actually make much difference. Now, they didn't talk about quarantining, because quarantining is something we've been doing for hundreds of years. What is quarantining? Well, quarantining is when you have someone that has an infectious disease and you know they have it and you isolate them from everyone else. That's what a quarantine is. It is not making everyone, whether you know they have it or not, shelter in place inside. That was a new and untried thing. This was based, there had been speculative models about the effects of these things, but we had absolutely no data that that was actually a beneficial thing. Moreover, the World Health Organization itself in October had said there was no reason to think that this was going to be beneficial. So it became very, very strange within a few months that became the sort of common sense intellectual orthodoxy, is that that's what we all absolutely needed to do. And so you can remember, though, that the initial argument for doing this, at least in the United States, was that we needed to flatten the curve. So that was the initial justification for a complete shutdown and a lockdown, was that what was going to happen is that the coronavirus was deadly enough that we were going to absolutely overwhelm the healthcare system, right? So overrun emergency rooms, overrun ICU wards and things like that. So what we needed to do is shut everything down to flatten the curve. So as opposed to a curve in which lots of people get sick, right, and end up in the hospital, we'll flatten it out over time. Now, here's a key thing to realize or to remember if you knew it before, is that the area under both curves is the same. So the number of cases or the number of people who get sick with the coronavirus, based on this assumption, was going to be the same. No one claimed initially that we could ultimately reduce the number of cases, the number of people that caught the virus by doing this. All they said is that by doing this, we will spread out over the course of the year the number of people that do it, so they're not all hitting the hospital system at once, right? So that was the idea. But there was no claim initially that doing these things was actually going to ultimately prevent everyone from catching it. That lasted about 2 weeks. In fact, the White House campaign was 15 days to flatten the curve, I think is what they called it. So for a few weeks, we were told that we would flatten the curve. And what happened? Well, we had in the United States a remarkable sort of effort by the Army Corps of Engineers and various volunteers to create temporary hospitals. The U.S. Navy Comfort ship docked in New York City. The Javits Center was built out with thousands of beds because of this assumption, right, that we were about to overwhelm the hospital system. That's what we focused our efforts on. They stayed empty. Now, New Jersey, New York, and Connecticut did have, obviously, they were the sort of epicenter of the virus. They had severe pressure initially on their healthcare system, but it was not overwhelmed in the way that had been predicted. Right, and so on April 1st, the Navy Comfort ship actually disappeared, and they dismantled the Javits Center. Now, so that's just one example of what happens if you don't understand the risk that you're facing. The response and the way in which you use your resources might be stupid, right? It might be counterproductive. That turns out that was a complete waste of time and money. At the same time, New York and New Jersey had policies in which they were requiring that old folks that were in nursing homes that caught the COVID-19 in hospitals had to be reintroduced into their long-term care facilities. So exactly the opposite of what you would have wanted to do. And so they had huge numbers of extra deaths as a result of that, right? So the argument started with flatten the curve. Then it moved to what? Well, essentially try to reduce the number of people who catch the virus. But remember, just a few weeks before, the whole assumption of the flatten the curve campaign was that that was not possible. We could sort of spread out the amount of time in which people caught the virus, but nobody actually, at least officials, didn't think that we should be under the illusion that we would do without these things if we just sort of locked everyone down. But here we are in July, and various states are still at different levels of lockdown. I'm in a sort of northern lying county in suburban Washington, D.C., just over the border in Maryland. We're still under a sort of partial lockdown orders. And what are we waiting for now? First it was to flatten the curve. Then initially it was, okay, maybe wait till the summer and reduce the number of cases. Now, waiting for cases to drop is a kind of foolish goal, and I'll explain why in a minute. We're now waiting for a vaccine. Seems like, insofar as I can see what the justification is for these policies, we're waiting until a vaccine comes online. Matt Schultz in a previous session talked about how useful vaccines, there's several sort of attempts to develop a vaccine. The bad news is that the FDA in the United States has never actually approved a vaccine for a coronavirus. It's because we've never developed a vaccine for any particular coronavirus. So it's not clear that that's even going to be possible, unfortunately. So here we are. The question is, did the lockdowns make any difference, right? Did they have an effect? So there wasn't any evidence that they had an effect. We're going to have an effect initially, but maybe they did. It turns out if you actually look at the data, it doesn't look like the government lockdowns actually made any difference to the spread of the virus. This is a very kind of depressing thing to say because we all, in the US, we suffered from this. But what you can do is you essentially take the curves, the data that we have for all the US states, and you can also compare different countries that had government lockdowns. We have the dates for the government lockdowns, right? So we know exactly when they happened. So now think ahead of time here. If you're going to test this hypothesis that government lockdowns reduce the rate of transmission, the number of deaths, the number of cases, right? What would that mean? Well, that would mean that there should be a signature in the numbers that tells you, right, the relevant time period after the lockdown happens, you should see the curve bend. If you're tracking cases, you should notice the signature in the data that says, okay, that's the result of the government lockdown. It's about a 10-day plus or minus period. So you need the lockdown, and then you need the time of transmission and incubation, time for people to get sick and go to the hospital and take a test, right? So it's about 10 days. So you'd expect a bit of a time lag, but you've got the date for the lockdown, and then you count out 10 days, and we should see a signature in all those curves, the different states and countries, if the lockdowns made a difference. Well, we do this in the book. We lay out all the data. So it's a bunch of graphs. And I can tell you, if first of all, they all look sort of different. But if you did not know the dates of the government lockdowns, you would never be able to guess it from the data. It's essentially random. Right now, of course, they all sort of happened in the spring. And so the curves started leveling off anyway. And so somebody could always say, well, maybe it was the result of the lockdowns, but that's making it essentially unfalsifiable, right? What you would expect is for the lockdowns to provide a signature in the data. And so the most modest thing we can say, at least, is that there's absolutely no evidence that the government lockdowns themselves actually made any difference, which is depressing, right? So whatever you think about it, and however forgiving we want to be of politicians, I think the brutal reality is that it just didn't do anything. It didn't do what it was supposed to do. So what were the costs of this? We estimate in the book that if we had just treated the coronavirus like a really bad flu, so let's say we treated it like the Asian flu, right, or the Hong Kong flu, which killed 1 million people in 1968 with the Hong Kong flu, let's say it was 4 times worse, that it would probably still have cost the economy maybe $200 billion. So it's not like it's cost free either way, right? So we would have had a response and it would have had a cost. But it would have been quite different. Well, the cost as we did it, because the costs were on lockdown, as you know, cumulatively something like 41 million new jobless claims in a 3-month period. In fact, I looked this up yesterday. So cumulative new jobless claims since basically the 1st of March are 52 million people. So what that means is that not all those people are necessarily still unemployed, but new jobless claims of 52 million people. I mean, there's 330 million in the whole United States, so that's an absolute disaster. The initial rescue package of about $2 trillion all added to the debt, and that's just money, right? There are likely to be tens, if not hundreds of thousands of excess deaths because of shutting down the healthcare system, right? And so there will be tens of thousands of people who will die of cancer that would have otherwise been screened from cancer. There will be thousands of deaths from anxiety and depression and suicide, so-called deaths of despair, as a result of our response. There was a huge devastation to the global food supply chain, and just in the United States, none of us suffered hunger. But we have 2 supply chains for food. We have one that's retail and wholesale that goes to grocery stores, and one that goes to restaurants. Well, we just completely destroyed the restaurant supply chain. So at one point in mid-March, just in Minnesota farmers were euthanizing 10,000 pigs a day. They had pigs that were ready to go, ready to be slaughtered, nowhere to go. And so we've got a 7,000 word depressing chapter about the cost of the response in the book. The point is that the cost of the response is going to vastly exceed whatever benefit there was. And in fact, it looks like the actual benefit from the lockdown. And that's only if you treat the lockdowns as a cost of 0 or a benefit of 0. It may be that the lockdowns themselves actually cause some excess deaths, because normally in a quarantine, you don't lock healthy and sick people together, especially with respiratory viruses. They're much more likely to catch it inside than out. So that's the kind of depressing thing. The other depressing thing is that the virus, as we all know now, is deadly, and it kills people, just like, you know, a cold virus and a flu virus can kill people, and a really bad strain can kill a lot of people. It's not nearly as deadly, of course, as the Imperial College London model had predicted. The infection fatality rate is basically the fatality rate of people that are infected, right? And of the people that get infected, how many die? We estimate that it's between 0.15 and 0.26% of the population. So it's a sort of bad flu strain, but it's not chronologically distributed evenly. It's distributed very heavily toward the elderly with comorbidities. And so if you are over 70, for instance, you're more likely to die of this than the flu. If you are under 17, you are about 20 times more likely to die of the flu than the coronavirus. right? And so the idea that you should lock down elementary schools to protect children is just completely bizarre. And that's the evidence itself. So that's the kind of sort of basic story. I honestly can say I thought in July everyone would realize what was happening, that the book would be obsolete because everybody would realize what would happen. But according to recent polls, people are still terrified of this thing. They still think that we have something like the Ebola has spread. And so we're still terrified. And for some reason, it has not sunk in. And I think the reason it's not sunk in is because of the power, the immediacy of a broadcast media, which is incentivized to terrify everyone, and then the immediacy of social media applications in which we are continually bombarded with terror for both kind of incentive reasons, fear sells, and also I think, honestly, in the United States, a media that's quite hostile to the president and is sort of hoping that this might prevent him from being elected in 2020. So that's where we are. So that's just a kind of brief rundown. And so with the rest of the time, Chris is joining me here, and we'll take some questions.
Yeah, that was fantastic. And we'll kind of go through the questions. The first question I think you addressed is, are there kind of deaths from the lockdown itself? I think the answer is clearly yes. This is a great one from Scott, Teresa, and JJ. They're asking, Sweden is held up as an example by both sides.
Yes.
What are your thoughts?
Yeah, and so I do think that Sweden actually had the basic attitude of herd immunity was exactly right. What you want to do in a situation like this is you want to protect the extremely vulnerable, and then the people that can catch it and can develop immunity, what you want is generally for them to catch it because they're at very low risk. And then once they've caught it and they're no longer spreading it, you're more likely to protect the people at risk. Sweden did do something wrong at the beginning. They did not seem to realize how dangerous it was for the elderly. And so they were not as careful as they should have been. If you look at the deaths in Sweden, again, it preferentially selected for the elderly in Sweden. People that know Sweden, you know, it's lots and lots of the elderly actually live in these long-term care facilities. And so they ended up with a lot more deaths than they would have. But I think the general response, which was rational, it's not that they didn't do anything. They just didn't do the kind of panicked lockdowns. If everybody compares Sweden to Norway and Denmark, who did better, right? And we assume that was the result of the lockdown. But that's taking 3 data points. Compare them to Belgium, which has basically the same latitude, had draconian lockdowns, and had enormous numbers of deaths. And so there's actually no correlation between countries that had government lockdowns and countries, ones that did and ones that didn't, in terms of either total deaths or deaths per million. So compare Sweden to the rest of Europe and not just to Denmark and Norway. And you'll see that, yeah, now the reality is viruses are going to do what they're going to do. And so any respiratory virus is going to be dangerous. The question is, you don't have a no risk scenario. So the question is, what's the response that will give us the greatest benefit without actually incurring costs that are actually worse than the thing we're trying to cure? That's the point. The point's not that the virus has no danger or that it can't kill people. It's that whatever the risk is, you want the response to be appropriate to it.
And I'd like to expand on it a little bit. And the big debate now is about masks. And I think similarly to what you're saying, if you look at the correlation charts between mask adoption and outbreaks, it's also very messy. It's inconclusive. Yeah. Can you go in a little further detail about the kind of mask debate? It's seen as either a kind of tyrannical infringement upon American rights or a sign of scientific enlightenment.
Yeah.
And this has become the symbol that we're fighting against.
It is.
What is going on?
And so it's the symbol. It's so much the symbol that if you Google the price of panic or look it up at Amazon, there's the picture on the front is a woman with a mask over her eyes, actually. So it is, it's the mascot. I couldn't do anything about it. Yeah. And so I will say, so there's not a lot of data about general populations using masks to prevent respiratory viruses or viruses in general, right? But part of the reason is because it's almost impossible to do that study. How are you going to do a double-blind randomized study with a control group and they've got to all do the same thing all the time? One's group's going to wear a mask, one's not. You can't study this. And so absence of evidence and evidence of absence are 2 different things. And so what you do is you say, is it mechanistically plausible that masks can make a difference? So if you wear an N95, for instance, so that filters out 95% of the relevant sized particles, and it's properly fitted, that will filter out 95% of certainly spittle and droplets, but also the aerosol particles that likely also transmit the virus. So all things being equal, don't take unnecessary risks. You wear an N95 that is properly fitted, so it's sealed. I think it's plausible that it's going to reduce the likelihood that you're going to catch the virus. Surgical mask, those are loose fitting. Those are mainly designed, and this is the sort of conventional wisdom, is that they're designed to protect the environment from you, not you from the environment. They're really designed, if you're a surgeon, so that if you cough or sneeze, you don't cough into somebody's body cavity during surgery, right? And so they would be good for that. And insofar as that prevents you from doing that, and you don't touch it with a dirty hand, and you don't wear a dirty one, right? And you don't pick your nose and keep fiddling with it, then it will probably somewhat reduce the sort of transmission. The problem is that the way that it's actually practiced, it's not clear if the benefits exceed the cost. So in my gym, for instance, we don't know what the effects of 100 people working out heavily with surgical masks on is. I'm guessing there's some negative consequences to this, since it makes me want to pass out, right? And so I do think everybody should try to be dispassionate about this, and don't allow yourself to be taken either in the, we're all going to die and you absolutely have to wear a mask, or you're trying to kill grandma on the one side, or it's it doesn't do anything and it's just purely the result of one globalist conspiracy on the other. It's like, yeah, okay, all things being equal, it might be a kind of low-cost thing to do if you're in a risky situation, but it's probably not going to make a huge amount of difference as it's actually practiced. And Chris, as you said, I mean, some countries like Taiwan, people automatically wear a mask if they feel sick. They did well, but it's not clear if the mask had anything to do with it. And so I suspect that all things being equal, if you do it exactly right, it will slightly reduce the risk of you catching it. That's the most I'd be willing to say.
Yeah, great. And let's see if there's one final question.
Indoors and outdoors.
Question from Richard. Richard is asking if you can comment on reports that the same person testing positive twice is counted as 2 confirmed cases of infection, and maybe more broadly, what are some of the kind of statistical manipulations that you found that they're using to create this panic, create this sense of fear? Okay,
so the first one is, yes, it is true. I for a while I just thought this was anecdotal, but that the same person being tested can be counted as 2 cases. But Bruce Chapman, the founder of Discovery Institute and President Emeritus, sitting right over here, he was tested. So he got it, Bruce, you got it in February, right, initially? Yeah. Here in Seattle, was tested in Florida, tested twice and confirmed that he had it. Both those tests counted as cases in Florida, even though he actually got it in Seattle. So that is true. We're trying to do something right now that nobody's ever tried to do, which is to count in real time the number of cases of pathogen and the number of deaths. This isn't actually possible to do. The number of flu deaths, for instance, actually determined after the fact based on complex statistical models. We're looking at Worldometer every day and thinking that we know exactly how many people are catching this. And so it's just intrinsically difficult and fraught with danger in the best of circumstances. We're not in the best of circumstances, though. Here's one kind of statistical trick that's happened, is that the focus went from deaths to cases. All right, so what was happening in March and April, and we knew our book wasn't coming out till October, so we just tweeted it to be on the record. Watch what's going to happen. The media is going to start talking about cases in the summer. Now, why are they going to do that? Well, they're going to do that because the total number of deaths is going down as the number of tests is going up. And so if the best way not to have any cases is not to do any tests, right? And so if a case requires that it have a confirmed test, you just don't do any tests, right? And then you don't know how many cases there are. There are cases, but they're not recorded. Now let's change the scenario. Imagine that you do 750,000 tests every day. Now that sounds crazy. Who's doing that? We're doing it. Right now in the United States, every single day we are doing at least 750,000 tests of a virus that's still spreading in the population and mostly asymptomatic. In March, the definition of a case was someone who basically went to the doctor, went to the hospital, had the relevant symptoms, was tested, and was confirmed, at least got a positive, right? It might have been false, but he had a positive, and they had the symptoms badly enough that they had to get treated for it. That was a case. A case now is testing positive, right? Even if you're entirely asymptomatic. And so by definition, if you amplify by an order of magnitude the number of tests, you're going to have a heck of a lot more cases. And now if everyone in the hospital is being tested, right? Everyone that goes to the hospital for any reason is tested. you're going to be sampling a bunch of people that are going to be positives, and people die in hospitals, right? So now all of a sudden we've got this correlation of people that are tested positive from COVID that are also dying. And now we're completely scrambling death from COVID-19 with death with COVID-19, right? And so this will all get disentangled 2 or 3 years from now. The problem is we're having to decide what to do right now. And it is an absolute nightmare. And it's especially a nightmare if you're reasonably competent in statistics and you're realizing the role of statistical models in absolutely dictating what all of us do. So it's easy to detect the old intellectual orthodoxies, the intellectual orthodoxy from last century, right? It's really easy to be against segregation for Americans now, right? The question is, what's happening right now? What's the intellectual orthodoxy right now? Are you able to discern that? That's where the real test is. And at the moment, we're in the middle, unfortunately, of what is in effect a social contagion, and we're required to rise above it.
Yeah, that's great. Yeah, I know that in Sacramento County, California, something like 70 or 80% of the recorded COVID deaths were people who are already in hospice.
Right.
And then contracted
Exactly.
COVID.
That's right.
Which is, I mean,
it's crazy.
It couldn't be more like, you could disentangle that causality very clearly.
Yes, exactly.
So that's great, and that's very timely. So I hope everyone enjoyed our final presentation for the day. So this is the wrap up. This has been the first ever online Gilder seminars. It went off without a hitch. Great thanks to Eric, who is the technological guru, to Nate back there, who is holding it down, answering questions, unmuting and muting very, very strategically, to all of our fellows, and then to all of our students, especially the Gilder seminar, college students and young people who were scheduled to come out to Seattle. Thank you for coming virtually. We hope to meet you at some point in the future. If you'd like to learn more, it's discovery.org. We have a wide range of programs. We have a wide range of articles and reviews and lectures and videos. Hope that you have a chance to check it out. You guys, I think, will be automatically signed up for the mailing list, so we'll stay in touch with you that way. And for those Gilder seminar students who had registered to come attend in person, we're going to be doing the same thing. It's going to be, I believe, the same Zoom link to participate with us, do an interactive Q&A. We're going to take about a 5-minute break. It's a different link. I'm just now being told in my earphone. It's a different link, so you'll be getting that in your email. You've already got it in your email. So join us there. And for everyone, thanks so much for participating. Feel free to reach out. We're happy to answer any further questions you have. Thanks so much, and see you next year.